Welcome back to Face the State. I'm Arianna Bennett. Thank you for keeping it here. A recent study showed a disturbing number of women report being dismissed or not taken seriously by their doctors when they tell them about pelvic pain or other vulvovaginal symptoms. And more than half said they weren't taken seriously. They considered it discontinuing care altogether. So why is this happening and what can we do about it? I'm back with Dr. Melissa Dawson with Urology Nevada. Dr. Dawson, thank you again for your time.
Yeah, thank you for having me.
So this study just came out this year, a couple months ago in March. Was it in any way a surprise to you?
Absolutely not. In fact, it was very validating for me. These are conditions we see every day. These are women that I treat every single day. And I spend a long time explaining and educating and trying to undo some of these common themes that I see over and over again, where women feel that they have somehow caused or propagate their symptoms.
My gosh.
Yeah.
There's a lot to unpack here. I just want to go over a couple of the highlights that I read in the study. So 52.8% were told their symptoms were normal despite substantial pain on examination. 42% were told they needed to relax more. 21% were told to drink alcohol to fix it. And 21% were referred to psychiatry without medical treatment. And all of this is just this picture of women coming to a doctor for help, probably embarrassed about something and being told you're overreacting.
Absolutely. So medical gaslighting, and it goes over the exact definition in the article, is when it's the invalidating of a patient's genuine clinical concern and not receiving proper medical evaluation for it. So many women don't even know that this is happening. So a lot of times, you know, this study really does validate what can be happening and, you know, all over the country. Hey, you just need to relax, you need to do something else, you're just getting older. But the reality is this is also seen more subtly when a provider comes in and they're feeling rushed, or the patient feels like they're being rushed. They're, discussing their symptoms. They don't feel like they're able to fully explain the situation. Maybe they're not receiving a full pelvic exam that day, even though they have a pelvic floor issue. All of those things can feel like the provider is not taking their symptom or the reason why they're there very seriously.
I think it's 2025.
Yeah. Oh, yeah.
It is frustrating, yeah. I think, when you look at all the progress and the fact that we have such equal representation now in higher education and in so many arenas. Medicine is becoming so much more common for women to become doctors than it ever used to be. And still, we are seeing these kind of pervasive issues where women are being dismissed when they have legitimate health concerns. We're not in first wave feminism anymore. How do you fix this?
I feel like I'd be a millionaire if I could answer that question, but I do think it comes down to two main issues that I think is happening. One, I think there is very much a need for education in pelvic floor dysfunction and disorders in medical education. So in medical schools, in advanced practice provider schools like PAs or NPs, in residencies, which is our training after medical school. We don't really get that sort of education. We don't see patients that have this sort of level of pain, and if they do, they are maybe going to a specialist. A lot of our medical training is done in big academic centers, so a lot of these pain patients are being subspecialized to pain management doctors or to other subspecialists that do pelvic floor dysfunctions like myself. So that's one thing, the lack of knowledge. But I also think there is a dismissive behavior that is rampant, unfortunately, in which we're finding and reporting on, where providers, for whatever reason, either feel like they're being rushed, because these patients do take time. We need more than 15 minutes to talk to a patient about a pelvic floor dysfunction or about a pain condition. you can't fit this into a 7-minute visit or 15-minute visit, which is the average time that we really get with patients. So there's other factors, unfortunately, but that dismissive behavior is one of them.
It's interesting. I think, you know, if you go online and you read about this stuff, you're going to see a whole lot of anecdotal stories from women who have dealt with that issue. And then another one that I think is really interesting, and that is pain management when it comes to procedures. So a really common one that I've heard talked about is IUD insertion without any kind of painkiller at all. Or no anesthesia, and it's not even a conversation, it's not even offered. This is beginning to shift though, right?
Absolutely. So there was a new guideline put out by the American College of Obstetricians and Gynecologists, also called ACOG. They put out a new guideline recently saying that we should be offering basically pain management for the in-office procedure, for the IUD placement, for an endometrial biopsy, for various things that we do in the office and not in the operating room. We should be at least offering patients some form of analgesia, like lidocaine sprays, creams. So we have topicals, we have injectables. We also can give patients by mouth medication. There's many things that we can do.
Like a pain pill to take ahead of time.
Sure.
Yeah. Why has this not happened before? I mean, we're talking about things like biopsies that are cutting a chunk of your body out with no pain management. And now again, 2025, and this is the first time we're talking about this.
Yeah. Again, there's a lot to unpack here. There's I have many different thoughts on this. I can't really answer that fairly. We don't really truly understand. But what we do know in our medical literature is that most of our literature from years and years ago really do come from studies done by white men for white men. And so it's taken a very long time to get to where we are now, and we still have a long way to go to find that equality in the literature for women's health.
So literally we're writing medical literature about a population that has totally different parts and a totally different experience, but treating it like we're just smaller men.
Yeah, I mean, I use the example all the time. Can you imagine a man going in for a vasectomy and not receiving any kind of pain management for that?
Right.
Yeah.
Well, it would never happen.
No.
It doesn't happen.
I mean, it makes me chuckle and laugh, but it's really very tragic.
Right.
Yeah.
And then things like, you hear about people who have endometriosis and it takes them a decade to get diagnosed because they go in and say they have, horrible menstrual pain, and the doctors just say, well, that's part of being a woman.
And I think we're seeing less and less of that as we gain more knowledge about endometriosis. I think that the diagnoses that we're seeing that are a little bit harder to treat now are like high-tone pelvic floor dysfunction, and which is a mouthful. But that's when a patient comes in and she can't sit for long periods of time because her pelvic floor is bothering her. She can't have any kind of intimate relations with her partner because she's so uncomfortable. She can't fall asleep at night because she needs to be in a certain position. So those sorts of things are very, those are hard for most specialists like OBGYNs and urologists and primary care doctors to really understand what's going on unless you're seeing a subspecialist like myself.
Yeah.
Yeah.
So reach out, ask for help. Okay, so now let's get to the solution piece.
Yeah.
So what do we look for in this patient-doctor interaction that tells us I need to be either pushing harder, advocating for myself more, or seeking a different opinion?
Absolutely. I feel like it's if you go to a provider and you feel like you're not being heard, and that's your interpretation. If you feel like you're going to a provider and they're not providing the correct evaluation that you feel like you need, as simple as a pelvic floor examination. If you feel like even if they do, if they listen and they do the examination, but you feel like their diagnoses are not accurate to what you're feeling, it's okay to get a second opinion. It's absolutely okay. And I tell my patients that all the time. Sometimes the patient has to feel comfortable with you. And if maybe even a personality, sometimes we don't jive. And that's okay. And maybe you need to hear it from another provider. And I feel very confident about the way that I diagnose patients, but my whole goal is to make that patient feel better. And I always say that. I want us to agree upon, your expectation for success. Let's do X, Y, and Z if you're comfortable with that. And if you don't feel comfortable with those options, please go seek other, another second opinion so you can also, see for yourself if this is something that is, going to help you.
Okay. Any major red flags that should be an instant, this doctor's not for me?
Again, to your interpretation, if you don't feel heard, if you feel like you're being dismissed, if you feel like the evaluation is not complete or thorough, you have permission to not only seek a second opinion, but you have permission to also not perform that treatment that doctor is recommending for you. That is okay. There is no shame in that. You know your body best, and you should be your own self-advocate. I really truly believe that.
All right, and then in searching for a second opinion or a first doctor, if they haven't gotten any opinion yet, what would you say we should be looking for?
That's a great question.
What do you look for? When you find a doctor for yourself, is there something that you look for?
I know. I feel like I have to jive with somebody. Like I have to feel like you're a real person and you understand what I'm saying. You're here in the room with me. You're not thinking about the next patient or the patient beforehand. And I feel like once I get your attention and when you're responding to me and we're having this conversation, I feel like, okay, he or she gets me. They understand what I'm saying. They're validating the symptoms that I have. They're asking more questions. They've looked at my history. And a lot of times I will repeat questions to a patient even though I know the answers from their history because I want to make sure that it's accurate. I always tell my nurse practitioners and PAs around me, I'm like, never trust another evaluation by anyone. Do your own evaluation, because although I work with phenomenal other providers and doctors, physicians in the area, I just want to make sure I can make my own assessment for myself and for my patient. And they feel validated that not only did that physician say the same thing, but we're coming to the same conclusion. So part of it is clicking with your provider and understanding, making sure that they're a real human and that they're listening to you, they're validating your symptoms. And then, for me, making sure that they do a thorough examination and that their recommendation is in line with what I feel would be a good treatment. I would say do your own research, but sometimes out there it's hard to get really good information. So we have some great websites and great resources that I usually give patients while we're in the office, and they can do their own homework and look online.
Okay, really good advice. We just have 30 seconds left. Do you have any final message you'd like people to take away?
Don't just do your Kegels, please see a pelvic floor specialist, a wonderful OBGYN, urologist, or urogynecologist like myself for full evaluation and recommendations for treatment.
Love that. Okay, Dr. Dawson, thank you so much. I sure appreciate your
me.
time. Well, that is it for this episode of Face the State. But for more information or to see past episodes, you can head to our website, it's 2news.com. Thank you so much for being with us. We'll see you next week.